seconds, and here we are. So thanks again for joining the webinar. And today I want to talk about frozen shoulder. And frozen shoulder, I really like sharing my techniques with frozen shoulder, and I feel lucky that I really have gained a lot of knowledge working with clients with frozen shoulder. And that's not just frozen shoulder, but also shoulder impingement, those type of issues, and so sometimes also thoracic outlet or thoracic inlet syndrome. So I've had a lot of, thankfully, a lot of success, and I love sharing this information. And I want to be able to get you, get you going and have you hit the ground running, and be able to help a lot of your clients and help the majority of people with frozen shoulder. So I'm going to give it to you in one word. I know there are a lot of techniques and a lot of modalities that can revolve around frozen shoulder, but I'm going to give it to you as far as like the big topic and what you need to focus on, in my opinion, with regards to frozen shoulder. I'm going to give it to you in one word, and that is scapula. You really need to know what's going on with the scapula when you work with frozen shoulder, or shoulder impingement or thoracic outlet. What happens to the scapula, or what's happening with the scapula and its relationships, the connective tissue around it, is going to affect what your client is going to feel, how your client is going to react, how their body's going to react, and then what they're going to tell you when they come in. So classically, when you have a client come to see you and they maybe say they have frozen shoulder or some sort of impingement syndrome, one of the first things you want to do, as always, is verify that diagnosis. Make sure that the client was properly diagnosed, so that you know exactly what's going on. It's possible that it could be many other things, so you want to make sure that it's that it is frozen shoulder before you proceed. So in textbook, they'll come in and they'll say that their arm hurts here, maybe around deltoid area, maybe around bicep area, and then when they want to bring up their arm, they can't bring up their arm all the way, so there's a limitation in the range of motion, and they feel pain in one area. And sometimes what they end up doing is they end up compensating and raising their shoulders in order to raise their arm. The same in this position, if they try to raise their arm this way, then they get some sort of range of motion limitation. So these are actually some of the range of motion tests that I do, just to see what their degree changes, or what their degree range of motion is before the session and what their degree changes after the session. So this is something I do every single time. How many degrees can you go up? And then after the work, they get to see the change, and hopefully they're encouraged by the results, and they're also encouraged to continue the work, because frozen shoulder is not something that goes away in one session. This is something that may require a series of sessions, and this is another thing that I encourage you to tell your clients, that you may need to work in a series of sessions in order to help that person's nervous system adapt to this new way of working. Because we had our natural way of working, and then the client established sort of other neuromotor pattern where now there's a muscle imbalance, and then when you start working with the client, then you start setting up a different neuromotor pattern that is hopefully the same, similar to their original one. So it takes time for that to happen with a lot of people. It's almost like you had your original software, and then there was a bug in that program. So now that program is now different, and now you're having to relay new software, new bug fixes, so that you have something similar to that original software. So what I try to do is understand what's happening with frozen shoulder. So one of the things that may be happening with frozen shoulder is what I mentioned before, is a muscle imbalance. And let's say, for example, the client can't lift up their arm that much. So something like this actually ends up looking more like raising their arm kind of up this way. And let me know if you can't see it. So what may be happening at this point, they may start to feel a pain up here and they say, oh, it hurts here. Well, what may be happening is that their deltoid and even part of their biceps are working to lift up the arm, whereas other areas, other muscle areas may be fighting against that action. So up to here where, we know classically that supraspinatus engages, and then after that, other muscles engage. But if we have the teres muscle group fighting and the latissimus muscle group fighting and engaging at the same time that these muscles try to engage, now the same as having the gas and the brake on at the same time. So I'll repeat this because this is important. If we try to raise our arm this way, and let's say the client tries to raise their arm this way and they start to feel pain in here, it could be that these muscles are engaging, and they shouldn't. They actually should be disengaging. And we have now a fight between these muscles and these muscles. Well, guess who's going to win? These are stronger. These are actually, much bigger and compared to the deltoid. And a lot of times people feel actually pain in the deltoid area. So even though my client may come in and saying it hurts here, what I usually let them know is, I acknowledge their pain. I know that they're feeling pain here, but I tell them I'm going to work around the scapula first, and then I'm going to come here, let them know that I'm listening to them. I'm going to come here and work this area last. This is usually what happens, not every single case, but what happens is then I go to the teres territory. Oh, thank you for that. Is the timing and the streaming off? Let me know if anyone else is having any streaming issues. Then I can look at what's going on and check it out. Maybe I can close some programs here. Let me know. Okay, I'm not. No one else is saying that their timing and streaming is off. But thank you for letting me know. We'll see. Maybe I'll slow it down a little bit, and hopefully it'll help. Okay. Okay, great. Yeah, if you're having any issues, folks, just feel free to log out and log back in. I'm actually, usually when I do the webinars, I'm tied with a cat cable, so I get the quickest, oh, yours is frozen. I'm sorry, it sounds like we're having some technical difficulties, but this hopefully is still recording, so we'll be able to get some webinar information for you in a later date. Please, if you're frozen, then go ahead and log out and then log back in. All right. So I'm going to continue with the webinar because I know it's going to be available later on. So again, this area may be actually working at the same time that this is. When I end up lifting my arm, these should engage, and then these should disengage, but with frozen shoulder, that doesn't always happen. It's actually funny that someone's frozen during the frozen shoulder webinar. I think that's kind of interesting. So maybe we can unfreeze the shoulder and unfreeze some of this data. So anyway, my attempt at humor on a Thursday evening. So what I end up doing is working this area here, and I will do usually, deep tissue work, or I could do muscle energy technique work, or I would even do trigger point work to help that tissue to disengage. So, a lot of that tissue may be just engaged this way, and when I do whatever modality, whatever technique I feel I need to do, then the hope is that it will disengage, and then we have kind of more of an allowance that this will then allow this area to work properly. Let me know, folks, if you're still frozen from in the streaming. So after that work, and maybe I'll do about 10 or 15 minutes of that. After that, then I have the client, we reassess. I have the client sit back up and we go through the motions again. And what ends up happening most of the time is that the client is able to bring up their arm without feeling the pain here, or maybe feeling minimal pain here. So if that's the case, then I know I'm on the right track. I know that I'm doing the right thing. And I continue with working tissue, not just in this area, but around the scapula. Remember the first word, the first thing I wanted to share is when it comes to frozen shoulder, think about scapula. So that being the case, let's see if we can get, I want to show you just a brief demonstration of what I mean by working the scapula, working around the scapula to help with frozen shoulder. So let's get Elena in here. Elena, have a seat. And I'm going to reset the camera here for a bit. So it looks like everyone is able to watch the video. Haven't heard any feedback about the streaming, but let me know if it's still slow. So again, here we have scapula. Let me get you a little closer. Great. And a little further away. Great. So here we have scapula. And if we imagine that the client is prone, sometimes I've worked with the client in but if I imagine that the client is prone, what I would do is put my hand here right on the scapular bone, and I would palpate. Remember, palpation is key in this work. It's a huge piece of the Morales method and of a lot of manual therapies. So what I end up doing is holding this scapula, and then I first start with taking the scapular tissue, the scapular bone, taking it in different directions. I will take it superiorly, and I will take it inferiorly, and I will move it laterally and move it medially. And when I do that, when I take the bone this way, and then I take it down, and then I move it medially, and then move it laterally, I start to feel a resistance. I start to feel what I call the directional resistance. And it's not just related to the scapular bone, but it's related to the connective tissue around it. So when I have my hand here, and I try to have my hand as a broad surface on that scapula, and I move the scapula down inferiorly, I try to feel where is that distant tug of tightness or resistance coming from. And when I do this, I feel some in Elena's shoulder. I feel some up in here in the upper trapezius area. Now, a lot of people say, oh, it's upper trapezius, and everyone is, seems to be obsessed with the upper traps. But don't forget the tissue that's underneath that upper trapezius tissue, and that is posterior scaling. A lot of times we think we're working trapezius, but we're actually working posterior scaling. And of course, if we're working posterior scaling, then we're also affecting what's happening up here by neck. So what I tend to do when I'm working up here is I will pull this tissue back, and this is some of the upper trapezius tissue, and I will sink in here. I will feel the tissue going down to the rib cage, which is, in this case, in this location, posterior scaling. So going back to our palpation, I'm bringing the scapula down, and I will feel, it's not just trapezius, but it could be tissue related to posterior scaling that's resisting. Now, you might be thinking, well, Marty, posterior scaling isn't attached to scapula, so how can that be? Well, we're not just working muscle-wise, we're working connective tissue-wise, and it could be that tissue from here attaching to trapezius, per se, for example, is also has fibrous connections to posterior scaling that could then be affecting neck. And of course, we have a direct connection of levator scapula from here to the neck. So that's one set of data that I get when I bring the scapula down. When I bring the scapula into medial to lateral direction, I feel tug, and it's not just all of this area, but when I do this, I feel some tug mainly around here, this lower part of rhomboids. So that may then be an area that I want to focus on. When I go lateral to medial, then I may feel definitely some tug, and it starts to happen all around here. So we may get into Terry's tissue, all that Terry's territory. And then when I take the scapula into clockwise rotation and counterclockwise rotation, now I start to get into more of a functional palpation. And I'm going to bring up her arm just a bit so you can see possibly some movement. And here I am taking the scapula into clockwise rotation. And what I'm feeling is a distant tug from scapula to another part. In this case, it's Terry's going over to humerus. And I feel, there's a little bit of a tug right around here. Elena doesn't have frozen shoulder, so if this was a frozen shoulder case, I would definitely feel some tug. It's a kind of a classic symptom where you feel some directional resistance here. And then when I go into counterclockwise direction, I'm not feeling that much of a tug anywhere except up in here in the upper trapezius area. So then I would go ahead and start working based on what I feel. Of course, because we are doing a Morales method manual therapy, by the time I get to this territory, I'm feeling directional resistance. So let's say I was feeling something up here in upper trapezius, I would sink into end range and I would take the tissue in different directions. And in this case, I feel directional resistance going this way. And so then that's how I would work it. If it was just a pure deep tissue or myofascial type of work, that's what it would look like. But if we were doing trigger point work, then I may find possibly some areas of potential trigger points in this area and then work the trigger point as you would. Just a little kind of tip on how we work the trigger point with the Morales method is I also feel the directional resistance. I also feel the DR of a potential trigger point, and then I work it. In addition to working the directional resistance on a trigger point, I also feel for directional ease. And we call that type of work where you work directional ease, we call it positional release. And I know that classically it may be called strain counter strain. So I take two approaches for quote unquote trigger points, one of them being a strain counter strain approach to the point. So enough talking. If I were working in here, I may feel some sort of tightness and I work it, and I may work it just like this in a static position, or I may anchor feeling directional resistance, and then I may move the arm to facilitate in that lengthening of the tissue and really of allowing the nervous system to give the signal for tissue to release. So I'm using my arm here to lift up her arm. It's much easier when I'm not anchoring down with my thumb. And when I anchor with my thumb, body mechanics is I have my thumb this way like this, and I sink in here, and then I take the tissue into this lengthening position. Again, this would be you're looking at this in sitting position. You mentioned how I would prop my client and position myself in order to work with the client in prone position. Is that okay?
Sure. That's sensitive.
Okay, so it's sensitive. I don't need to go into too crazy deep in here for the demonstration, but you get the picture. Here's where my thumb is. I could follow that all along. I know the classic rotator cuff muscles, and they are definitely involved in the frozen shoulder situation. I just worked some of the teres muscles. I could work supraspinatus as well in here. And I could also go to infraspinatus and see what's happening there with the infraspinatus. So once I did my work, I would then reassess. What does the scapula look like now? And actually, that's pretty interesting. I actually feel like, I'm going to bring your arm down just to make sure I have the same reading. I actually feel there's a little bit more movement just from that demonstration work. I don't know if you feel that or not, but I feel, not sure, that's fine. I actually feel a little bit more movement, which is interesting, just from a a minute or so of working. So, keep in mind this area, keep in mind this area when you're working with the shoulder. And then, of course, your client's going to come in and classically say that that front part of their arm, is bothering them or hurts. When you reassess and you have them move again, ask them how that feels. And I would say go there and work that tissue. Feel again for the directional resistance of that tissue. Feel for the directional ease of that tissue. A lot of times you'll get some sort of muscle spasm, which may indicate that that tissue is releasing, and then now, instead of tied up like that, it can now move from a more lengthened position. I've had quite a number of folks come to see me, and this is essentially what I share in my frozen shoulder workshop. But this is a big part of how I work with a lot of my clients. Of course, like I kind of alluded to, this is related to neck. So you may end up having to travel up and work on your client's neck. Another thing I want to mention, thanks, Elena. Another thing I want to mention, and it's not just with frozen shoulder, but with a lot of issues and conditions that clients have. They may tell you, oh, my shoulder feels great, but now I feel pain in my neck. And they may tell you like, oh, the pain traveled up to my neck, or heaven forbid, they may say, oh, now you caused the pain in my neck. Sometimes that may happen. But, one thing I want you to look into and also use as an educational tool is look into pain gate theory. So pain-gate theory. And what that theory states is that we may not actually be feeling all the pain that we're feeling. A client that comes in with arm ache because they have frozen shoulder may also have issues in their neck, but they're not actually feeling it because right now their brain is registering the pain that's happening here. But once all of that gets alleviated, now they have room in their system to acknowledge the pain that's happening in their neck. So keep that in mind. You can Google pain gate theory, and you may even print it out for some clients so that they understand what's happening. It's an interesting thing to note that they may actually be feeling everything that is happening in their body, but that's our body's way of keeping the sanity, so to speak. So that's it, folks. If you have any questions, feel free to ask. Again, this will be up for recording. Keep in mind the scapula. Get that scapula mobile. When the scapula is mobile, then the arm can move, and then we won't have some of that muscular strain that's going on with the arm and frozen shoulder. So get that scapula moving, get your folks feeling better. Thanks again for watching this webinar. I hope to see you in future trainings, and hope to have you in future webinars. Alrighty, have a great evening.